Nice.
Are we good? Are we live? You guys seeing me? Sorry, I was doing some last minute touch-ups here on my title, making sure we got you guys covered. We're going to be covering the 5 essential tips to heal cartilage and avoid a knee replacement today. We got a great topic. I especially am happy to share number 5 because it's going to be a really good way of thinking about how to go about treatments that you see every day, what doctors recommend, what friends and family members recommend. So if you have knee arthritis and you're looking to avoid a knee replacement surgery, you want to fix the problem at the root, this call is going to be excellent for you guys. I'm Dr. David Midoff. I'm the owner of El Paso Manual Physical Therapy. I've got all kinds of help and programs for people who have knee osteoarthritis as well as other issues. But today we're going to be focusing on knee osteoarthritis. So who's with us? Who's here? Who's missing the soccer game to watch us here? Hope you guys are going to get some value here. If you're catching us on the replay, you guys can still comment. We love to see your comments, even if you're watching the replay. Rose Garden says, hello, Doc and everyone. Fantastic. Salome says, has a wavy hand, a pink wavy hand. I love it. Cindy King says, good afternoon from Odessa, Texas. She's our regulars. Look at the twins in that photo. I love it, Cindy. That's great. You are blessed. You are so blessed with those babies. Julie Parker says, hello from Sydney, Australia. Julie's one of our regulars who joins us at whatever time it is. I don't even want to ask. I feel bad asking Julie what time it is over there. Cindy says, hi, Dr. David and staff. And Kimberly's here. Kimberly's been with us a while, and she's always here. She says, hi, Dr. David, EPMPT, and everyone. My staff is waving hellos at you. Lori Wilson says, hello from Ohio. What's up, Lori? Thanks for joining us over in Ohio. We got a question here. Mine is always here with questions. Hello, Dr. David. What happens to the cartilage in grade 2 chondromalacia patella? Does it have a chance to heal in 30s? So you're in your 30s. What are the signs that cartilage is healing? Thank you. And then we have another comment. Also, would like to request you to also make a video on your own healing journey, the challenges, the stuff that helped, etc., as you are my go-to person for genuine information regarding chondromalacia. Oh, of course, I'm happy to help you out. We'll have to look at that for sure. I did recover from chondromalacia patella and patellofemoral pain syndrome. I've had all kinds of knee issues as I was growing up. Hopefully, my knees stay healthy. They're doing great. I ran somebody else has my phone, 4.2 miles this morning. I ran 5.5 miles Sunday, 2 days ago, and lifted weights yesterday, and I feel pretty good. And I bike to work every day. So I think I've healed from chondromalacia. To answer your question directly, what happens to cartilage in grade 2? You have a chance to heal. Any cartilage damage has a chance to heal. Now, there's definitely a threshold, like a point where the damage is so bad that it's like we need to do something a little more invasive, potentially like replace a joint. That would be arthritis. But if you just have chondromalacia patella and you're motioning your knee is decent, like you can bend it and you can straighten it out, then what should happen is the cartilage can rebound. You can get the space back in there if you can fix the imbalance. This is my opinion, by the way. Like, there's no research evidence to back this up because there's none done. There's none that shows that it just that you completely lose it. There's just speculation at this point, based on what tends to happen. But there's nobody addressing muscle imbalances in research that I know of. So I think it's possible. The other thing that I'm extrapolating from our knowledge that we do have available, in other words, what I'm assuming based on my expertise and patients that I've worked with and all that, is that scar tissue develops. And we know this very well based on your own body. Like, if you cut yourself, you get a scar, right? And so, like, I have a scar here, and you can see that right in that area right there. That was from a car accident, and it's healed. But it's different than my regular skin, but it still serves a purpose and it works. And so I think the same thing can happen inside your joints where there's cartilage. You can get scar tissue, and that's okay. That's not a bad thing. We have negative associations with scar tissue, but it's actually a good thing. So I can talk more about my story later. I think that'll be definitely helpful for a lot of people. All right, up next, Kimberly says, here for my weekly dose of encouragement. I love it. I'm here to encourage you all. Dr. Lyons is here, sizzling in Los Angeles. So sorry, we're pretty hot out here too. I'm sure it's just as hot, if not worse, over there. Mark is in Long Beach. Awesome. That sounds amazing. We have Nicole, who's in Orlando, Florida. Thank you for the invaluable info. Absolutely. I'm happy to help. I love doing this. Yvonne is here from El Paso, a fellow El Paso. I don't think we've had an El Paso on our live stream ever. Welcome, Yvonne. Glad you're here. Barbara Smith says she's in Gary, Indiana. Awesome. We got Barbara in the Midwest. That's fantastic. We have Regina, who's here from Missouri. Just glad to be here. I love it. Thanks for joining us, Regina. Julie Parker, it's 5 a.m. You must be an early bird, Julie. Thanks for joining us in the wee hours over in Australia. Janet is in Aztec, New Mexico. Oh, cool. That's our neighboring state. Maybe you're not too far away from us. Thanks, Janetta. And then Breathing Spaces says, hi, team. Thank you. Cheers from Miami Beach. Awesome. We got people in some awesome locations all over the world. Jose is in, he says, hi, Dr. David. I'm glad to see you. I'm from Minnesota. Oh, I love it. What do you think about dry needling for rotator cuff partial tear? I think you could try it. It's not going to fix the problem. It's not going to heal a rotator cuff tear, but it might help with the pain. It might help get some of the muscles to calm down that are contributing to pain in the short term, so that you can then do the work to fix the long-term problem. So I'm not against it. I just want everybody to be educated about what is fixing the long-term problem and what's actually just giving you some short-term relief, but isn't fixing the root issue. So it's up to you if you want to try it out. There's a lot of PTs that are doing dry needling, and I don't know that they're explicitly saying like this is going to solve your problem forever, but I feel like they convey that, doctors too, physicians. So just know that it's not fixing the root problem. It's a short-term thing, but that's potentially helpful. Hope that helps, Jose. Karen from South Africa. Awesome. We have Africa checking in. We got people from all over. I love this. Yvonne for our El Pasoan says, knee pain for about 6 months. Ortho doctor gave me a cortisone shot 8 days ago and has not kicked in. So sorry, Yvonne. When does cortisone shots kick in and for how long? It should have kicked in by now. If it hasn't kicked in by now, it's probably not going to work for you. This happens sometimes. You're in one of the unfortunate situations, Yvonne, where it didn't work for whatever reason. There's multiple reasons. One, they missed. That could have happened. I definitely, if you're going to get a cortisone shot, a pain injection for simpler terms, for this goes for for everyone, not just for you, Yvonne. There's doctors out there that do this ultrasound guided. So they use an ultrasound tool like what they would use to look at a baby inside of mommy's tummy as a baby's forming. But they can see your joint, and then they'll use the needle to go in and make sure they get the right spot. They'll do that in the hip as well. That's generally helpful, although the knee is kind of easy to get into, so it's kind of hard to mess up. So there's a possibility that it's just not going to be effective for you. It didn't work. Could have been the medication, could have been the severity of your knee issue. There's a lot of factors here. I wouldn't like go blaming the doctor and say, doctor, you messed me up, or you suck, or you missed the joint. There's a lot of variables. It's hard to say that it was just a doctor. What I think the take-home message for you, Yvonne, is there's something else at play. I know this was a way to get some relief, but you need to be fixing something else so that we can get you some long-term relief. But glad you tried it out. Now you know. Nancy says, Dr. David, I have arthritis and tears in my meniscus. I am trying to figure out which of your programs to sign up that will be beneficial for me. Oh, this is a straightforward answer, Nancy. If you have arthritis, that's the worst condition compared to just a meniscus tear. So I'm assuming arthritis in your knee. Do the knee arthritis recovery program if you're trying to, like, if you've decided you're going to do one of our programs, definitely do the knee arthritis recovery program because you have knee arthritis. The knee arthritis recovery program is also designed with the fact that I kept in mind that the fact that most people who have arthritis also have a meniscus tear. I mean, if you ask, like, if you actually get into the program and you ask in the membership community, our private community, probably more than half of the people, and they'll be like, "Yep, I got a meniscus tear. I had an operation on my meniscus. I've got multiple tears." They have them, so you'll be helped anyway. That's definitely the better route to go. Now, if you only have a meniscus tear but no arthritis, then the meniscus recovery program would be better for you. But I definitely recommend the arthritis program for you. Love it. All right, let's get to our scheduled programming here. We're going to cover this is the 5 essential tips to heal cartilage and avoid a knee replacement surgery. This is excellent information if you're just starting out looking for how to fix knee arthritis, how to avoid surgery. If your doctor told you you need a surgery, they diagnosed you recently with arthritis, they said, they give you the x-ray and they're like, hey, look, your bones are touching, bone on bone, loss of cartilage. That's the classic thing that the doctors will say. And then they'll usually say, well, we could wait a year, see how it goes. We could try this, this, and that. Usually injections, pain medications, physical therapy. And if that doesn't work, eventually we'll need surgery. That's a lot of people's story. This information is going to help that kind of person. All right. So, and like I said earlier, number 5 is it's awesome. I'm excited to get there. They all kind of build up towards number 5. Let's talk about number 1, though. The number 1 thing that you need to do like today, if you're just learning about this information, is we need to figure out how to manage flare-ups. Just going to write management. Flare-up management. This is huge because what happens is your knee might be swollen, it might be painful, and because it's swollen and painful, you probably can't walk very long. That often happens. Sometimes people don't have any swelling or pain, but they feel their knee hurt and they're looking for a place to sit after they've been on their feet walking or just standing for a while. All those signs are consistent with knee arthritis. People who have knee osteoarthritis get those issues. The other one too, the other one that I talk about a lot is pain at night, because there are some of you guys out there that don't have any swelling, feel fine for the most part during the day, maybe a twinge here or there, but nothing that stops you in your tracks. And then you can stand and walk as long as you need to for your life, for what you do. But when nighttime comes around and you want to go to sleep, it's not fun. Your knee hurts you. It's hard to get in a comfortable position, and you're possibly losing sleep at night because of pain in your knee. That's that other variable that some people feel. Some people have all 4 of those things or some combination of those 4. All of them are consistent with knee arthritis. And here's the issue is people are trying different things, like getting an injection like Yvonne or El Paso in here, or they're taking pain medications. They're going to go get procedures from the doctor, or they're trying exercises out that they found here and there. And they're just kind of shooting in the dark. They're trying a variety of different things, pain creams, hot and cold. There's all kinds of different things you could try. And sometimes they give relief, sometimes they don't. Sometimes they give relief for a while, and then they stop. They stop helping. Figuring out a process to manage your flare-ups is what's missing. Because you have to understand that some things might work for a time. Like take knee braces, for example. You might put on a knee brace, a sleeve, something. There's all kinds of braces. That's a whole other talk. But let's say you put on a brace, whatever it is, and you start walking around, you're like, oh, better. I feel good. Let's go tackle the day. And then after 2 weeks, you're like, I don't know about this brace anymore. It's not working out. Maybe I need a different one. Maybe I need a new one. What do you do then? And that's where the management part of flare-up management comes in, because it's not that the knee brace was a complete loss. It's not that Tylenol you were taking stopped working, or that injection that you did have that did actually help you, unlike Yvonne. You felt relief right away and you're like, oh, I'm 100%, let's go. You have to just realize that there's different things to try out depending on what's working. You have to have an arsenal of many tools in your toolbox of flare-up management treatment options for yourself. And so just understanding that's a big deal. And the reason why it's so important is because I truly believe that so many people have tried different things, but they haven't really organized the information and figured out which ones are the best ones for them, and they end up going to surgery way sooner than they should have because they couldn't manage the flare up. They're just constantly flared up. The longer you remain flared up, the harder it is to flare it down. It just takes more time and effort. And then they give up and say, all right, doc, I'm ready. Let's see. I tried the injection. I tried physical therapy. I tried sign me up for surgery and let's get this taken care of. And they give up. And really, if they just tried some tried and true treatment options, they would get some massive relief. And so here's some simple ones that I'll recommend. I'm going to put A here. Offloading. Nobody does this. Nobody recommends it. And then people don't follow through on it as good as they should. Like once people join our knee arthritis recovery program, we're getting on their case about doing this properly. I'll talk more about it here in a second. Another one is using a massage gun. Since these came out a few years ago, maybe it's been 10 years or so now, these are revolutionary in my opinion. And then for C, tailgate swings. And I'll talk about all of these tailgate swings. These are our best recommendations for flare-up management. Notice injections aren't here, medications aren't here. These are our top three. And I'm not saying that the medications or injections aren't options for you. They might be. I've talked about that. I'm happy to answer comments if you guys have questions about those. But these are the ones that work best. And I'm going to put these into number 5. I'll tell you more about that. But let's talk about offloading real quick. Offloading, for those of you guys that are just figuring this out, it's using devices like these. This is a walker. This is a crutch. We need to get our other one back. Do we have a cane by chance? A cane is another option. We don't have one with us right now. It's okay. But a walker, the whole purpose, let's say it's my left knee that's the issue. It's the one that has knee arthritis, the one that hurts, the one that I'm trying to manage because it's flared up right now. What I want to do is whenever I'm on my feet, and I know this is an inconvenience, guys, but this is what you have to do at the beginning to properly offload. Whenever you're on your feet, have this around, this walker, so that when you go walk to the bathroom, walk to the kitchen, walk through the parking lot, wherever you need to walk, you're not putting your full body weight through that painful knee. You're putting some of the weight through your hands and the device. So when I step with my right foot, I'm putting most of my weight through the walker, then bringing my left foot up. So that way, this left knee that I'm trying to offload isn't getting the full body weight. Because the point of cartilage, we're talking about cartilage today. The point of cartilage in the body is to cushion two bones on each other. Because the bones have to be pushed against each other in order to work. They have to move on each other. There's tendons and ligaments that pull the joint together. It sucks it together so that it can move properly. That's supposed to happen. So there's supposed to be some pressure there. Cartilage is designed to take pressure. But when it takes too much pressure for too long, that's when we run into problems. That's when osteoarthritis sets in. So to heal it, to get it to calm down, we have to take pressure off. But life goes on, right? You still need to get around. You still need to move and do things. So let's do it with some support so that you're not putting too much pressure and you give that knee a chance to rest. The crutches can provide 100% offloading. If pretend I had 2 crutches here, I would be moving similar to like how I was doing with the walker. The idea is the walker's just a little bigger. You have to figure out how you're going to manage the devices, what's better for you. Crutches love to fall down. They're not very stable. Canes love to fall down too. There's options out there that are more stable, but walkers tend to be the best. And I have this walker on our set here, but there's other walkers. There's walkers that have wheels on all 4 legs, and they move a lot easier. They even have a seat. There's some very fancy walkers out there, have hand brakes and all that. And they're potentially good options for you, especially if you have to walk longer distances and you feel like you need to find a place to sit. But this offloading stuff, let me make this point. It's never, I can't think of one person that's ever told me that it's been recommended to them. It is never recommended before knee replacement surgery. They'll push you to go get medications, injections, have all kinds of procedures done, like genicular artery embolization, genicular nerve ablation. Like you can look those up. They're the procedures that are done. You even get the knee replacement. And before we go to the knee replacement, which is a completely non-reversible situation, they never say, why don't you try offloading? That's never even a thought. It's never even a consideration. And it is extremely valuable, because if you can take a week, maybe even as little as a few days, maybe you need a couple of weeks where you're consistently offloading and you can get your pain to calm down. That might be the difference between being able to sleep a full night of rest or being able to tolerate more walking, get the swelling under control. That moves you in the right direction, but offloading is not recommended enough. So my advice to you is, this is one of the essential tips to heal your cartilage. Get offloaded as soon as possible. And I would go maximum, go to the walker, because then you spend less time being offloaded than if you're using a cane, because the cane only offloads you 20% of your body weight. I mean, if that, this can offload you 100%, because you can hold your leg up the whole time as you're moving. You don't have to put any weight. Same with the crutches. You don't have to put any weight on your leg. It's just going to feel a little funny to hold it up like this. All right, so that's the offloading. Let's talk about the massage gun. The massage gun is another option for getting the flare-ups managed. Let's say it's my right leg here. I'll talk more about the muscle imbalance here, but an assumption you're going to have to go off of here is this muscle very often in knee arthritis is overused, overdeveloped. It's too strong. Even if you feel like you're a weak person or you don't have much muscle on your body, it's a relative imbalance. You don't have to be, super strong. It's relative to your body. So these muscles, the quadricep muscles in the front of the thighs, are stronger compared to your glutes. And as a result, they tend to hold some tension. Just like when you go work out, your muscles firm up, you get increased tone, you get toned. That's what they always say. You're not flabby, you're toned now. These muscles tend to be toned in people who have knee arthritis. And as a result, you might dig in there, like with a massage gun. Let me turn it on. There's a massage gun. You can push the massage gun in different areas on your thigh. You might find a tender spot, and that tender spot is a spot where the muscle's just a little more, it's got increased tone. Some people call that a trigger point. I don't really use that terminology. What I care about is that spot is tender, and if you hang out by pressing the massage gun on that spot, you can move it around a little bit, just kind of keep the massage head in contact with the same skin as you move it around, kind of moving the skin above the muscle. After 30 to 60 seconds, it goes away or it reduces tremendously. And then you move to the next spot that's a little tender. Do the same thing. I'm moving the skin. I'm kind of pinning my skin down with the massage gun and moving the skin over the muscle. After 30 seconds or so, it feels better. And then you go through your whole quad muscle. And after a few minutes of this, literally not more than 5 minutes, you would have freed up the muscle, and all those tender spots, those trigger points, if you will, those spots where the muscle's just a little more contracted or flexed or toned up, that adds up to a shortened muscle, which compresses the knee joint. And if you can do this on a regular basis, what I tell people early on in our program is you need to be using this all day. I mean, several times a day, 4 or 5, maybe 10 times a day, so that you can get the muscle to free up. That then reduces the pressure at the knee joint and can massively help with flare-up management. It just needs to be frequently. You can't just do this once a day, even twice a day. All right, and the last one for flare-up management is tailgate swings. And it's simple. It's so easy. This is it. I'm just swinging my legs back and forth. You can alternate them. You can move them together like this. It doesn't matter. The point of this is to circulate the fluid inside your knee joint, because if you're still, it doesn't circulate. You have to realize that the fluid inside your knee joint is what heals cartilage. And you cannot rely on your heart. Your heart pumps blood through your body, and it kind of moves all the fluid within your circulatory system inside your muscles, your skin. But your fluid inside your knee joint is not directly connected to the heart. It's moved around by movement. So you have to move your legs around like this in order to get that to circulate. And when you circulate it, then you assist that fluid, the synovial fluid, the knee joint fluid, in moving around and kind of bathing the surfaces inside your knee, the cartilage included, which helps to move the waste products out of the cartilage as it's trying to heal and bring it new elements that it needs to heal. You know, the oxygen, all the nutrients that it needs, fresh water from your the way your body makes it in the synovial fluid. It just brings good stuff to your cartilage and it takes out the bad stuff by doing this. Tons of people get a lot of relief from doing this. These three treatment options that I'm showing you, the offloading, massage gun, and tailgate swings, are my best recommendations to practice good flare-up management. All right, guys, we're gonna take a call. I got Sherry from Colorado who's got a meniscus tear. Sherry, are you there? This is Dr. David.
I am. Hello, sir. How are you?
Hi, Sherry. Doing fantastic. Happy to talk to you. How can I help?
Well, I'll try to give you a really quick rundown. I got this wonderful recliner chair.
Oh, nice.
And noticed that the footrest was very stiff from the string.
Okay.
Springs. So I thought, oh, good, leg exercises. So I started lifting up and pushing down, lifting up and pushing down, and I ended up with 2 bubbles under my knee.
Oh, no. Like on the back of your knees?
The front, under my kneecap.
Got it.
Very painful, and also on one of the sides of my knee, right by the knee.
Okay.
And it's stinging, very, very painful.
Yeah.
So I could hardly walk. Went to the doctor. She sent me to PT.
Yeah.
Yesterday was my 4th appointment at PT. Everything's been going pretty well.
Okay.
They've got a reformer, which I love.
Uh-huh.
I've been doing like clamshells and stuff, things like that. I'm very, very weak, which I didn't know how weak I was.
Oh.
But yes, I know. Yesterday she asked me they had bands on the top of the door.
Okay.
She asked me to hold on to those and do sit downs up and off a chair.
Okay.
And after having watched you a couple days ago, you just showed up on my YouTube. I knew that tendon or whatever it is, it goes over your kneecap.
Yeah.
And up your thigh.
Yeah.
You know, I'm like, absolutely not. I can feel it. It's tightening over my kneecap.
Yeah.
This doctor I saw on TV, I think that's a no-no. And yes. And she was like, well, you know, everybody has their own way. And I said, yeah, but I don't think I'm going to continue.
Yeah.
So I learned I could say no.
Yeah.
But what those bubbles? I didn't have X-rays because I'm used to having been, you know, getting around pretty well.
Yeah.
But what are those little bubbles? They're still poochy. They almost look like fat deposits.
Yeah.
But I know they're not. Could that be the meniscus that popped out? And also, could you just real quick do a quick synopsis on the back muscles, what exercises to do for the back of your legs to strengthen that muscle instead of the top muscles of your legs? Okay. I know to hold in my butt muscles when I'm doing stuff. Yeah. But yeah.
Absolutely. Let me tell you. So the bubbles that you're describing below the kneecap area and then on the sides of the knees, whether it's the inside or the outside, those are typically associated inside. Those are typically associated with inflammation of some tissue in the area. I have never once in my career, I'm not saying it's not possible, but I have never once seen the meniscus actually popped out of place. Maybe that's something that just is an emergency situation and I don't see that person. But my suspicion is that if you're functioning, even though you might be in pain, what I mean by you're functioning, like you're able to walk around, you're able to bend and straighten out your knee and do life to some degree, even though you're hurting, chances are your meniscus is still in position. It's still in place. And what you're likely experiencing is inflammation of a ligament or a tendon, like tendonitis, maybe bursitis. A bursa is actually inflamed too. You can also get fat pad impingement, Hoffa's fat pad syndrome. They have different names, but basically there's another structure there that can get inflamed, and it might be tender to touch, and it might be right near your meniscus too. So it's probably just inflammation. That's the most straightforward answer that I can give you. Then as far as the exercises for the back of your knee, back of your leg, I would actually discourage you from doing exercises for the back of your leg at this point, because given the inflammation that you probably have that you're describing, there's too much pressure coming from the muscles on the front of your thigh that go down and connect down to the front of your shin, the top of your shin bone below your kneecap. And so if you work out the back muscles, the muscles on the back of your leg, that would be your hamstring muscles, they actually can compress the knee too. And so what I think you were doing with the recliner was forcefully pushing down the footrest to work out the back leg muscles. And I would advise against that because it creates more compression at the knee. So the better thing to do is to double down, triple down on glute exercises, butt muscle exercises, because what that does is it forces your movements, your regular movements, like getting up out of a chair, to be butt muscle focused. And then secondarily, you have to use your thigh muscles of the front and the back of the thigh. They have to work. They're going to work, but you're making your glutes, your butt muscles, start and do the majority of the work whenever you're going to go stand up. And if you don't train your body that way, where you're using your glutes more, then by default, your body just says, well, I don't have glutes to use very much, but thigh muscles are working right. So let's use those to stand up and sit down. And that's what you tend to use. That increases the compression of the joint over time. Is that making sense?
Yeah. Can you show me you standing up specifically using your glute, your butt muscles?
Yes, I can. But before I do that, let me just say one thing. At the beginning, when you're figuring out how to turn on your glute muscles and use them, it's a very deliberate thing. Like, it's not just like you can flip a switch and you do it all the time. You have to be thinking about it. Like, you have to stop and pause and say, okay, I'm going to move to the edge of the chair, wherever I'm sitting, and then I'm going to think about tightening my butt muscles. Like, you have to be able to tighten them up. Some people can't do that. So you might need to do some separate work to get to that point. Then once you can tighten your butt muscles, usually your knees have to be open. And then you have to think, okay, butt muscles, help me up. And you tighten your butt muscles as you stand up. And they should feel like they're tightened up for a moment when you get to the top. That would be the very deliberate, conscious way to do this. And that's necessary if you're not in the habit of doing that. But what it should morph into over time is you should get stronger in your glutes and your butt muscles with other exercises that we talk about in our programs, we talk about on this channel, so that when you do stand up without thinking about it, because that's going to happen, right? You get up out of a chair all day. You're more likely to use your glutes more often. So you're not having to be so consciously deliberate about it. You following?
Okay. Yes. In fact, she's had me working on a table, strengthening my glute muscles and bringing my tummy in. And you find out quickly how uncoordinated you are. And you do have to focus on your butt muscles.
Yeah.
And it's like, okay. So sitting up, I noticed, okay, your knees are apart.
Yep.
Which is good, because I was wondering also, can my knees be apart? Do they have to be together? So I see knees apart is okay.
Yeah.
And
it's actually necessary, because when you bring your knees together, you are going to forcefully use your quads, your thigh muscles a lot more. It's harder to use your glutes if your knees are together. Some people can kind of do it, but as soon as you open up your knees, your glutes turn on a lot easier.
Okay. Okay. So this doesn't hurt your knees to be practicing standing up using your glute muscles.
It should help. It should feel better. Now, the one issue is if your knees are already angry and irritated, like you said, which might be the case for you because you
Yeah.
said you have the irritation, the inflammation down there.
Like half a golf ball on each
Yeah.
inside of my knee.
Then you might need to first focus on offloading, on doing some of the feel good stuff, the calm flare up management stuff before you get to fixing the muscle imbalance. We need to do one before the other.
Okay, and approximately how long does it take for that swelling to go down?
Good question. It depends on how well you can stop irritating it. It's, I hate giving those answers. I remember being a kid and getting kind of smart aleck answers like that, like it takes as long as it takes. But it's the truth, it's because if I give you a number right now, if I say it's going to take 4 weeks or 8 weeks, whatever it is, but you're doing the exercise you were talking about, or at physical therapy, they have you doing something that's irritating it, it might stay irritated past 4 weeks. Assuming you do everything correctly, then it could go away in as little as a week or two. But
That's not it. It's going on. It's going on probably about 2 months now.
yeah,
But I just started my fourth twice a week physical therapy, and I've had 2 weeks of it. So,
yeah,
so if you feel stinging or pain, say no. Don't try to be
yes,
Miss America doing it.
correct, that's right. Yeah, because anything that irritates it, anything that causes more pain or stinging, it's like picking at a scab on your skin. You're just going to start the bleeding all over again. You're going to have to go through the healing process all over again. That's what keeps the inflammation there way longer than it should have been.
Well, you've been a big help.
I'm
Thank
glad.
you.
I'm glad. And it's tough because what you probably need is being on crutches for a little bit or a walker, but going to physical therapy, I'm sure that would throw the physical therapist for a loop because they'd say, we need to be doing exercises. If I just have you walking or cycling because that's not full pressure, we're not being as productive as we could be. It's confounding. It's contradictory to what mainstream medicine has you do. So I'm glad that you're going through this process and learning. That's what you need. And this goes for everybody else listening too. I appreciate you being transparent and sharing all this story. Thank you so much.
Well, thank you for taking my call. I appreciate you.
Of course. Have a wonderful day.
You too. Bye-bye.
Bye-bye. Can I get the charts? Love that call. That was such a good, helpful call. And it definitely applies to so many of you guys out there. She didn't say directly that she had knee osteoarthritis, but it's the exact same principles. You guys that have knee arthritis might also have a meniscus that gets irritated, or you feel that deep ache behind your kneecap or just deep in the knee joint. And it just gets worse whenever you're doing more, you're on your feet more, or if you exercise, if you go walk, or even if you just do your chores, whatever you have to do to survive your normal daily things. And having to stop and slow down and think about how you're doing it, what exactly is aggravating it, is what's necessary. You can't just always exercise it away. We have to figure out how to relieve the pressure in the short term, and then in the long term, fix the root problem. Let's answer some comments here. Let's see what you guys have so far. Who's up first? We have Nicole, who says, yes, I do massage gun on quads and hamstrings, and it works very well for my sciatica. Awesome. Yeah, those muscles can, on the hamstrings, especially on the back of the thigh, they're right on top of and around the sciatic nerve. And the sciatic nerve innervates, it provides nerves to the hamstring muscles. And so as a result of that, if you have sciatica problems, which a lot of people with knee arthritis do, it can cause those muscles, those hamstring muscles in the back of the thigh, to want to tighten up. And so just be careful with not digging in too hard and actually pushing, affecting the sciatic nerve. So as long as you're doing it in a way that's helping you, I think you're on the right track, Nicole. Good job. Roby says, can you use that in the bend of your knee on the outside also? I assume you're talking about the massage gun. No, I would not put the massage gun anywhere where there's, let me say that differently. Only use a massage gun where there's muscles. and where you have soft tissue, basically. Let me just show you so that you're not confused about this. So I think what Roby was asking is, can you put the massage gun here or here, like right where my knee bends? And my answer to that is no, because it's not going to feel good. You're going to be bouncing on your bones, on the harder parts of your knee. You need to be in the softer parts up here where there's muscle. That goes for anywhere in the body, by the way. You shouldn't be putting this like on your ankle bones, on the hardest parts of your hip bones. You want to be on the softer parts because we're trying to relax the muscles that are overactive. So that would be the guidance on the massage gun use. And people will do it on accident. So you'll realize when you're on a bone, you'll start bouncing the massage gun in a way that it isn't productive and doesn't feel good. And then once you get on a muscle, you're like, oh, okay, I found the spot, and that feels like it's helping. Good question. Right, we have a bigger question here, 2 parts. Julie Parker says, I got told pointing my toes outward doing the sit to stand was wrong by my physio. Okay, so turning your toes out. Yep, we see that all the time. How do you loosen really tight tendons? Okay, let me answer the first part first. There is tons of debate in the medical field as to position of foot with all kinds of things, with the way you walk, the way you run, how you do squats, how you stand. People are so opinionated about it. And I have my opinion too, of course. And just to give you my clear explanation of this is I tell people to generally turn your toes out. But that's not where it ends. You have to realize the why. What I'm concerned about is making your glutes turn on. And when you turn your toes out, it just sets up your glutes to kind of want to turn on better. But if you can make your glutes turn on and your feet are straight ahead or even in, and they turn on best, by the way, because you can always say, well, I turn my toes in and my glutes turn on. Yeah, but do they turn on better when you turn out? Well, turn them out, because that's going to make your glutes work better. That's my straight up simple answer. If the toe in, toe out isn't connected to better muscle function, then I think they're just regurgitating a recommendation that they got somewhere in school, somewhere by a mentor. They just inherited that knowledge from somebody, and they're not really thinking it through. That's what I think is going on there, honestly. They're just saying, well, this is the way that you're supposed to do it. The other influence that I see is there's people in the fitness and health world that they connect athletes, high-level athletes, professional athletes, Olympians who toe in. They're compensating. They toe in when they run or when they play their sport, whatever it is. And so they think, well, if that Olympian or that top-tier athlete is doing it, then it must be good. And what I don't think they're connecting is that person's a genetic freak. I mean, if you can jump that high or run that fast or throw that far or that accurately or hit the ball, whatever it is, you've been training for a long time and you've figured out how to do it in a compensated way. You can't connect that to everyone exactly. We have to go off of muscle function, the way your muscles work, because that's what's going to fix arthritis. Hope that helps you out with that part, Julie. And the other part is how do you loosen really tight tendons? Tendons are what connect muscles to a bone. And so you can't really loosen a tendon, but you can loosen a muscle. And my recommendation is to start with one of these guys, a massage gun, loosen the muscle, and that'll take tension off the tendons. And then by fixing the muscle imbalance, because if you fix the muscle imbalance, you put the right tensions through your muscles and therefore tendons as well. Excellent questions, guys. All right, let's get back to the lesson here today. Let me just put this massage gun over here. It's going to fall on my ledge. All right, number 2. We need to reduce joint pressure. You have to reduce joint pressure in order for arthritis to feel better. So I've already been talking about this with the offloading. So I'm going to just put that here again. Offloading. I'm just going to put OL for offloading. You have to realize that Cartilage is a weight-bearing structure, and if it's injured, if it's irritated, it cannot bear weight normally. You have to allow it to heal. And then because it's part of your body, you have to realize that the body is a living thing. Your cartilage too, your bones too. They have they have processes happening inside cells, and most importantly, they adapt. In other words, when you put forces through them, they adapt positively or negatively. Just think of muscles. Muscles get bigger when you lift heavier weights. And so if you want bigger muscles, you should gradually lift heavier weights. Gradually is a key word I said there. You don't say, well, I can pick up 10 pounds right now. Let me go pick up 50 pounds and I should be able to gain more muscle. If you do that back to back, like within a day or a week or even a month or two, it's not going to work. You have to first pick up the 15-pound weights, then work your way up, hang out there for a couple of weeks, then work your way up to the 20-pound weights and hang out there for a while and so forth until you work your way up to 50 pounds over the span of many months, if not a year or more. That's how the body adapts. It's gradual. The same is true for other body parts, like bones and tendons and ligaments and cartilage. We don't think of it that way with cartilage, but think about this. You guys have ever seen bodybuilders or the ones that I think of, the extreme of the world's strongest man competitions. If you've ever seen this, you could Google it or look it up on YouTube. These guys picking up cars, I mean, attached to devices. They're holding these rocks that are hundreds and hundreds of pounds, and they're walking around with them. They're doing all these feats of strength. They have like ropes or chains tied up to like a big 18-wheeler Mack truck, and they're pulling it so far, and they're racing to do it. They're doing these incredibly these crazy things. But what I think of is what is that guy's knee cartilage like? Because in order to be able to pick up hundreds, thousands of pounds, your cartilage has to be prepared to take it. And I don't think that guy got that kind of strength overnight. It happened over the course of a long time. If we're just talking about being able to walk for longer, we need your cartilage to be healthier. So let's offload it, well, to get it to heal, then gradually load it to get it to adapt in a positive way. And we have to first fix muscle imbalances. So that's my next one right here is muscle imbalance, MI, correction needs to happen. I'll get into the muscle imbalance here in a second, but muscle imbalance correction fixes the pressures in the joint. And that's critical because if you do that, if you go through the process of fixing the muscle imbalance, then you can have more normal forces in your joint as you do your everyday things, as you wash the dishes and do the laundry and cook a meal. You can get out of the offloading and get into just regular muscle imbalance correction, then you're fixing the joint pressure. All right, number 3, you need to learn how cartilage heals. This is huge because people don't even think cartilage can heal. Let me just start there. In the medical field, there are, I don't know what the polls are or like what the percentages are of doctors that think that cartilage heals, but I think it's probably the majority. When I talk to other healthcare professionals and the topic comes up, they're like, oh, it's not going to heal. It's almost nonchalantly said. It's just an assumption that they think that everyone believes. And when I make a stance against that belief, that I'm usually met with like, oh, I never saw it that way. That makes sense. I explain it. I talk about what I was talking about earlier, how it's a tissue that can respond to forces. And if you offload it, it can have a chance to heal. It can get scar tissue, and that's not a bad thing. Scar tissue can be useful. Then as that cartilage can heal and is no longer painful, it's no longer irritated, it can adapt in a way that's favorable for you. It can get thicker or potentially more, what's the right word? It has better integrity. It can take more. And that's good for you because now you can start to work up from being able to just walk around your house to do your daily chores to maybe going on walks or hiking. or tolerating some other exercise that you love to do, playing pickleball, walking your dog, playing with the grandkids. You can get to that point, but we have to learn how cartilage heals. And the way that cartilage heals is by taking pressure off of irritated cartilage and then loading on the right kind of cartilage. And the part that I want to emphasize here is the learn part. Learning, let me underline it for you. Because my biggest concern here, I've already explained how cartilage heals, but really believing that it could heal and thinking about the processes. Because, I could talk to you all day about how this happens, how cartilage can heal, the cellular changes that happen, and the histamine responses and all the sciencey stuff. But do you believe it? Is it change? Is the belief about this changing your actions? Because if you're like, well, yeah, I heard it, but I don't know if I believe it. Then it's not. Then why are you here? Go get the surgery or go through the mainstream medicine process, and hopefully they'll help you out, which is going to end in surgery very likely. But if you really believe that this is a possibility that cartilage can heal, so we haven't disproven it. It's the mainstream belief. But what you have to realize is there's no hard research that says it is not possible. There's just a strong belief that that cartilage doesn't heal because there's no research to support it. They'll even say it that way. There's no research to support that cartilage can heal. But that doesn't mean that it's proven that it doesn't heal. It just means we don't know. We haven't investigated it. We don't have hard evidence that shows that it's possible. And the mainstream medical model pushes people towards ways to not really heal it. We're in the stone age of medical research, in my opinion. We've had some cool discoveries. We've had some amazing innovations. Knee replacement surgery is a heck of a human achievement. But I think it's overdone. And I think it's causing some problems as a result of that. And you guys can avoid them by first learning how cartilage heals. All right, let's go to number 4 here. I'm so excited for number 5. Habit changes those, something we need to talk about. Before I get into this, I want to let you guys know that the helpline is open. There's the phone number right there, 915-200-4159. We already took a call. We might take 1 or 2 more calls. So if you guys have a burning question, please jump in, give us a call. So let me get into habit changes. So what I mean by this is you need to begin to activate your glutes. That's early on. If you're fixing the muscle imbalance, you're going to activate your glutes. That's part of the process, which, by the way, let me explain that real quick. When I say activate your glutes and habit changes, this is the phases chart from our knee arthritis recovery program. And what this is you're looking at the stages of healing for arthritis. I've divided it up into 4. And the way that you know what stage you're in is by looking at the criteria here and figuring out what you have. And you just need 1 criteria from a lower phase to be in that phase. So you might feel like you're here, but your time on feet is less than 10 minutes and you're actually down here. That's how that works. And same is true for the other criteria. And this is free, by the way. I've made access to this free, and the materials from phase 1 are also free for you guys to access on our website. But the reason why I'm bringing this up is because habit changes are built into this program as we go along through the phases. Specifically, in phase 3 of our program, what I'm asking people to do is to begin to use their glute muscles, their butt muscles, in their everyday activities. So like when you get up out of a chair, like I was talking about on a call earlier, you need to be using your glutes. And then when you walk down the hall of your home to the kitchen or wherever you start your day, you should be using your glutes. And then as you go outside your home to do things you need to do outside your home, glutes should be active there too. As you squat down to pick up the sock that missed the laundry basket, glutes should be involved there. It needs to become a habit. If you're not using your glutes that way, then you're not going to fix knee arthritis. This is important because what the mainstream medical model is doing is saying, let's do these exercises at physical therapy and kind of keep them up. Do your leg extensions, jump on a bike, go on a walk, but there's no connection to which muscles you're using, and there's no habit building there. You might build the habit of doing your physical therapy exercises. There's people that I love Coach Jay's description of how he talks about his family member who went to physical therapy, got a printout of exercises, put them on the fridge, and maybe they were doing them, maybe not. But that happens a lot. And people will say, oh, look at that exercise. I'll do that one while I'm here at the sink washing the dishes. I can pick up my leg and move it this way. And I'm doing my knee exercise. But you're not learning how to use the right muscles in your everyday routine. And that's what I'm talking about by habit changes. You have to involve your glutes regularly. And it might seem like a lot right now because you can't activate your glutes or you're not very good at it. But like anything else, it's just a learning curve you have to go through. And then after a few months of this process, it's normal. We have people in our program all the time that are like, oh, I already learned how to use my glutes. It's happening all the time. I don't even think about it as much anymore. My glutes are good. I'm just working this other part of the program now. These habit changes are incredibly important. And in my opinion, it's what's missing, a huge part of what's missing in the mainstream medical model. The assumption in the mainstream medical model is that you just do this treatment and then you're better and you don't have to think about the treatment anymore. Right? It's passive. It's get this injection, get this ablation or this embolization done, or get these stem cells, get this treatment done. And then let's just see how it works. Meanwhile, you keep up your daily life doing the same thing the same way you've done them. That's not going to work to have a long-term change. That's just short-term at best. So that's what I mean by habit changes here. All right, we're going to go to number 5. For number 5, I have to draw you guys a picture. I won't even label it. Let me just get this square going here because the way to think of this, it's going to give you a good way to frame what I'm talking about. So I'm going to put quick, and then we have lasting up here. This is relief. I might have spelled that wrong. I think I did. You get it right. You guys type in comments if you have them right now. As I set this up, I'm gonna write correct here and then cover. And then this is problems. Okay, you want me to answer a comment first?
It's just one that I want you to read.
Okay, I'll get into this in just a second. What's the comment? Julie Parker says, hey, I asked Google, how does cartilage heal? And AI gave the explanation you say and mentions your YouTube channel. Great, we're making some improvements here. Thank you for doing that, Julie. I appreciate it. That's cool. The mission is moving forward. I'm trying to get us to heal here, not just cover the problem as I'm going to talk about here. I love it. Okay, here's how this quadrant framework works. On the top here, we have relief. So there's quick relief and lasting relief. Okay, then on the sides here, we're talking about the problem, things that correct the problem. And what I'm referring to is the root problem of knee osteoarthritis. Things that correct the root problem of knee osteoarthritis versus things that just cover the problem of knee osteoarthritis. They don't correct it, they just cover it up. So you can imagine what goes where, but let's talk about this a little bit. Let's start at this square right here. So quick relief, and just covers up the problems. We're talking about things like pain medications, it's all right, meds, pain injections. You could put knee braces on here. It's quick relief. What else do I have on here? Pain creams. This could be like, your Bengay, Icy Hot, Tiger Balm, those kinds of things. I'm not saying they're not useful. Don't take this the wrong way. I'm just saying you need to have a clear understanding of what it's going to do. It's only going to cover the problem and give you some quick relief. And you might need that. You might need to get sleep tonight and you want pain medication. You might have things you have to do over the next few weeks and you need a pain injection. You might need to be on your feet for a while and the brace is a solution that works for you in the short term. That's okay. I think it's cool. It's fine. There's other things I have on here that aren't going to fit, but I have like TENS units, E-stim, shockwave treatments, PRP injections, stem cell injections. All of these are covering the issue. They're not really solving or correcting the issue, and they tend to be on the quicker side. I don't have like hard time frames, but that's this. And the way that I would label this section here is this is Band-Aid stuff. All right, Band-Aid is just covering up the problem. All right, now let's go to quick relief, but actually helps correct the problem. Here we're talking about things like the massage gun, which I mentioned earlier. It can give you some pretty quick relief. It takes a few minutes to do. Yeah, you have to be doing it a lot, but you can get instant relief almost. I also have offloading. Absolutely instant relief. It's just harder to implement. Some people are like, oh, I have to walk around with this thing. Yeah, but it gives you relief, and it actually is helping to correct the problem. It's taking pressure off the cartilage. That's useful, very useful. Because here you just cover it up, but you're still putting pressure on your cartilage. You're not correcting it. Glute activation. If you're not good at firing your glutes, you need to start. And for some people, you may or may not be one of these. Actually, comment if you are. Some people figure out, you guys watching here, my audience, you guys figure out how to turn on your glutes like in a day or in a couple of days, and you start activating your glutes and you get knee pain relief. It can instantly help you get knee pain relief. Some of you guys have a little struggle with it. Some of you guys have other issues going on. And it's not as instant, but there are definitely people, I see the comments you guys leave, and some people are like, wow, I didn't know the glutes were such a big deal. Figured out how to fire them, and my knee pain's gone. So glute activation is another one. What I would call this section is the bridge, because it's bridging you towards the lasting section over here. Let's go down here next. Lasting relief, but is only covering the problem. The obvious one is going to be surgery. It's a non-reversible situation, surgery. So it's lasting. But it's not solving the root problem of knee arthritis. It's just removing your knee joint and replacing it with artificial parts. Some other ones would be genicular artery embolization, genicular nerve ablation. Those are procedures that are done where they're burning the nerves in the nerve ablation, and then with the embolization, they're intentionally blocking arteries, blood vessels in your knee to help with the pain as well. These are more lasting solutions, generally speaking, but they're not solving the root problem. They're just turning off the pain nerves, if you will. And then the extreme, because some people have surgery, sadly, doesn't go well. Some have a great outcome. That's fantastic. But if it continues to bother them, they might even need to get an amputation. I mean, to think that that's a possibility, right? To think that somebody has a surgery, a knee replacement done, something happens, doesn't go well for whatever reason, and they get to the point where they say, just cut it off. And the doctor's like, yeah, that's a good idea. Let's do it. You're subjecting yourself to that if you end up having the surgery. So what I would call this section is the trade-off, because this is the trade-off, right? You're saying, I'm agreeing to have a procedure done, like a surgery, and the trade-off is I can't go back. This is not reversible. You can't, once you have your leg amputated, it's gone. You have to wear another device now. You have to completely change your life. All right, now the final quadrant over here, which the bridge connects to, these are your lasting relief. This gives you very long-term relief, indefinite, essentially the cure, and it corrects the problem. This would be glute strengthening, so I'm gonna write STR, foot strengthening, ab strengthening. This is essentially muscle imbalance correction. I'll talk about amputation in a second. Correcting the muscle imbalance and then learning how to use those muscles in your everyday activities, like I was talking about with habit changes, like using your glutes while you walk down the hall, while you walk at the store, while you do your daily chores. When you go exercise, your glutes are a part of that exercise pretty consistently. This right here is gold. You can't get to this part, though, very often without going through the bridge first. And a lot of people spend all their time down here in the Band-Aid and the trade-off section. That's the medical model. Is let's start with all the pain relief stuff, injections. Let's go to physical therapy and do some exercises that don't really fix the problem. That's just covering the problem. Then let's end up having surgery or getting the embolization or the ablation done, when we should be spending all our time up here as best as possible. Maybe dipping into the Band-Aid section from time to time and only coming to the trade-off section when you've done all you could up here in the bridge and bridging into the gold section. All right, let me answer the amputation questions, and then we'll see what other questions people have.
They're just asking in general.
Oh, there's like, seriously, yes, it is an option. There are people who have had their legs amputated because they have a knee replacement surgery and they get an infection for whatever reason, or it doesn't work out, and they'll do a revision usually. Like they'll try to replace the knee, replace it again. But when they do the second replacement, the revision surgery, they have to cut more bone. The parts are different than the first time, and if it doesn't work the second time, you've already lost more bone. You get to the point where the doctor's going to say, we can't even do the next revision. We can't do the third or fourth surgery. So the next option in line is amputation. If your knee is still bothering you that bad, we're just going to cut it off, and you're better off with a bionic leg, with a prosthetic leg and foot. And that means you're probably going to spend a lot more time in a wheelchair. But the person that agrees to that, they're like, yeah, it hurts that bad. I can't do anything. I can't function. I would rather move on in life. I'd rather live with the trade-off of not having my leg because I'm so miserable with my leg. Amputation is sometimes done. It's rare, very rare, but it is sometimes done. Let's take a call. We have Catherine, who has hip pain in New Mexico. Hey, Catherine, this is Dr. David. Are you there?
Hi, Dr. David. I'm still watching you. Let me turn you off.
Oh,
Okay.
thanks for joining us, Catherine. I'm so happy to meet you. How can I help?
So I'm thinking that I am in phase 1 for hip, and I'm not. So first I stand, then I clench my glutes, and that pops me a little bit forward, not very much.
Okay.
And then I go down with my legs apart and my knees going out. I go down an inch or two.
Okay.
And then I hold that tight for 10, and then I relax, which is not exactly comfortable. And then I clench again and hold for 10, relax, clench for 10, hold again, relax.
It sounds like you're doing mini squats.
Yeah, I didn't know what they were called.
Yep.
Even though you've said them many times.
That's okay.
So,
exercises have all kinds of names. Don't feel bad about that.
So is that how I'm supposed to be doing that?
Well, if you're in phase one, we don't usually recommend that exercise quite yet. What's recommended
Oh,
in
that's
phase one
fantastic.
is offloading, using the massage gun, doing things that promote pain relief. And that exercise doesn't promote pain relief, it promotes muscle activation and strengthening, glute muscle activation and strengthening. And if you're still very irritated in your hip, like it hurts to do things, regular, easy, simple things, we can look at the criteria. I have them here. Um, if you're getting worse or staying the same, even not improving, then that exercise is not good for you yet. It will probably be good soon, but we need to do some things to calm the joint down first.
So, so here is my next question,
Uh-huh.
which is what happens in phase one. It says day pain 4 to 7 days a week. Well, I'm sitting here right now and I'm not having pain.
Okay.
If I move, yes, I'm probably going to have some degree of pain. Maybe not much, but
Yeah.
I'm going to be feeling something unpleasant. So does that count as 4 to 7 days?
Yes, it does. If just
does,
simple
okay.
movements, yeah, you don't have to be at rest. You can be moving, but what I would count there is your simple everyday movements. Your everyday movements. Let me just take out the word simple. What you do regularly to live, if during the day while you're awake, if you start to get some pain as you're doing it, that qualifies you as having day pain.
Day pain.
Yeah.
Okay. Morning stiffness, I do not have stiffness. Night pain, I used to wake up in the middle of the night with pain, but that hasn't happened in several months.
Good.
But if I turn the wrong way, it's not going to wake me. But if I am awake and I turn in the bed the wrong way, then it can hurt.
Okay.
So does that count as night pain? It's not waking me up anymore. But
how often do you have that? Would you say it's once a week?
It depends on. I'm not being waked at night with pain anymore.
Okay.
But if I'm awake and I happen to turn, maybe I turn toward the left side, which is the owie side.
Yeah.
That would hurt.
Well, let me ask it this way, because I understand that the hip pain is not waking you up at night, but if you're awake at night for whatever reason, like maybe you get up to go to the bathroom or get a drink of water or something, or go check on the front door, make sure it's locked, that kind of thing. If you feel your hip bother you at that point, I would count that as night pain. The thing is, your body behaves different at night than it does during the day. Your activity is a lot lower during the night. The only exception that I would make for this is if you're flipped completely on your, like if you're a night person and you sleep all day and you're active at night, you maybe work at night, or you maybe worked at night and you're still kind of a night person, then that's really your day. Does that make sense? Like I have a relative like that. He doesn't go to sleep until 4 a.m., but he wakes up in the afternoon, and that's he's flip-flopped that way.
I would say an average would be 10:30 at night, and then awake at 5 in the morning, go to the bathroom, and go back to sleep till 7 or so. So I'm basically, and then time on feet.
Yeah.
I was on my feet probably for 3 hours straight today.
Wow. How'd you do?
So, well, as long as I lean on the cane, I'm fine.
Okay. So without the cane, it starts to bother you?
Well, without the cane, then I cannot offload the weight. And if I put weight on the left hip, how do I say this? One trick that I heard somewhere on your things said turn, so it's the left hip for me. It said turn the left foot out. That aligns the femur with the place that it's going in my hips.
Yes.
it gets it more in. That and the twitching have been the most useful. So that one thing you're asking me, how do I do without the cane? If I happen to have that happening, that the leg is turned out, I'm facing forward, not bending left or right, then actually I walked earlier today. I walked maybe 20 feet, and I had sensation, but I did not have any pain. But that means I'm taking 3 or 4 steps, and then I'm stopping, and then I'm clenching my glute again and holding it clenched while I walk another. But there was not pain.
Okay. So you have day pain, though. It seems like it's almost every day. So that automatically qualifies you for phase 1. The time on feet, though, you said you've been on your feet for 3 hours already today, but using a cane, I would count the time on feet without using a cane. And so if we were to, I'm not saying take it away and measure right now, because you already have the day pain, so that qualifies you, but you're masking the pain on feet by using the cane, which is good. I want you to, because we need to offload. You're offloading. That's fantastic. But there's a day pain still.
Standing, I was not using the cane all the time. There were quite a few times, if I'm just standing, it was not pain. If I was going to move, if I was going to walk, I was cleaning out boxes and the library and stuff. So there wasn't much movement. And then I would grab the cane if I was actually going to move. But just standing, I was not in pain. It's moving.
Good. And this is okay. So this is why I built the criteria this way, because it fits most people's lifestyles, because there's a variety of different lifestyles. Like if you think about what your regular activities are during the day, it might look completely different from someone else's. Like you might be a busy bee who's bouncing around your house, keeping it organized and making sure everything's, spick and span. You might be somebody who prefers to not do much at home, but you're active outside your home. So that's why there's these different criteria. But we found it. You're in phase 1 for sure.
Okay. And so glutes, the last one in here is cannot. Pretty much, I'm putting I'm putting my hand on the front of my upper leg, and I'm not feeling tightening. Or I'm sometimes later on in the day, I do feel it, but it's very lightweight. It's the glutes definitely are much stronger. But earlier in the day, I'm pretty good about avoiding the hip, not the hip. So what do you call it? The front flexor, the ones you don't want us to be flexing.
The hip flexors on the front side of the hip.
Well, I don't know what they're called, but they are on the front.
Yeah,
the top of my thigh.
Yeah,
top of my leg.
Those are the ones you don't want to be activating regularly. The ones on the back of your hip, the butt muscles, those are the ones that you want to be activating. I just want to make sure I'm clear.
Yeah. So when I put my hand on the front of my left leg, mostly in the morning, I am not feeling any tightening there.
Okay, and you're trying.
And when I feel on the back, I'm definitely feeling the glutes.
Got it. Good. That's excellent. You're on the right track then. So you are able to activate your glutes instead of other muscles flexing when you try to activate your glutes. Good. Well, we narrowed it down. So see, what you did there is you told me where you stand in each of the criteria here in phase 1, which is exactly what I recommend everybody doing. What you just went through right now, Catherine, is golden for you. And everyone else should be doing the same thing. You need to get this graph, screenshot this, and look at it closely, or go look on our website where we have the hip arthritis recovery program phase 1 for free. You can also find it there, and figure out where you are. We also have a quiz, by the way. Do you guys want to talk about the quiz real quick? or maybe when I'm done would be a better part. A better part. Um, but once you figure out where you're at, here's the takeaway. If you just have one criteria from that lower phase, you're in that lower phase, and that's okay. Because this is where what people try to rationalize is they start to say, well, I'm more phase 2. I don't have this, I don't have that. I'm good at night. I can be on my feet. I just have that day pain. I'm more phase 2, so let me do the phase 2 exercises. And that's what typically causes problems, is because these are just too hard for you. We need to make sure we get that day pain under control better. And so stick to the phase 1 stuff until that day pain goes down to the phase 2 criteria level, which is 1 to 3 days a week.
And that little bitty crunch, that is a phase 2 thing. So stop doing that.
Yep.
Correct?
Yeah, the ab exercises that you talk. Oh, you mean the mini squat exercise you were telling me at the beginning, where you're doing the
squat?
Yeah, that
squat, no mini squat.
right. That's a phase 2 exercise. You're absolutely right, Catherine.
Now, is lunge phase 1 or phase 2?
Oh my goodness, that's the end of phase 3. I think we're talking farther ahead.
Oh, I'm sorry. I didn't mean lunge. My bad.
Oh,
Hinge.
oh, the hip hinge. The hip hinge. I believe
Yeah.
it's in phase 2. Pretty sure it's in phase 2.
Oh, so stop that one also.
Yep.
Okay.
Yep.
All right.
This is good. Oh my gosh, I'm so happy for you, Catherine. You're figuring this out. I love it.
I had no glutes at all 3 months ago.
Oh.
Not on the left side. On the right side, yes, I had glutes. But I had, I went to, this might be interesting to people. I went to clench my left glute, and my whole body shook.
Yes.
I just stood there and I could not get the glute to be tight.
Yep.
Just utterly useless. So I've come a long way.
Absolutely. That's fantastic, Catherine. Good job on making that effort, because you're not the only one. So many people will try to tighten their glutes and they just don't want to work. Other things work instead. Well, congratulations to you.
Well, thank you for telling me what I can do so I don't hurt. And especially that the foot going out to the side thing. That's magic. I want to ask you one last thing about time on feet.
Okay.
If I'm just standing and maybe taking one step to the right or one step to the left, I can have 10 minutes with no pain.
Okay.
Without the cane.
Yep.
But as soon as I want to walk, then we're in trouble.
Yeah.
So this says time on feet.
Yeah.
But does that really mean time on feet walking?
My intention behind that, Catherine, is doing your regular daily activities when you're on your feet.
Oh, so being able to walk.
Right. Walking in your home. So the way that I would measure it is when it's time to do the laundry and clean the bathroom and cook a meal, something like that, something that takes 10 minutes or so. How do your hips feel at that point? That's how I would look at that. Because the way you're telling me, if you just stand up and sidestep one way and the other way, that's not a fully practical thing that you probably do on a consistent basis. But I'm sure you'd take care of your home, do the things you have to do to cook a meal, things like that. Go to the grocery store. Those things take, a considerable amount of time, you being on your feet. And the reason why I say be on your feet versus walking, because cooking a meal, you might walk from the kitchen to another room or from the refrigerator to the stove to the counter. You're taking short walks, 5-6 steps here and there, but then you're standing for several minutes as you're chopping up food or as you're heating up food on the stove, whatever it might be. So it's combined for that reason.
So I will give you some good news on your way out of the telephone.
Oh.
This accident was 4 years ago, and about when I started doing your wiggle and other things, watching
by fidgeting.
you on before, fidgeted. Thank you.
Yeah.
I would find that sometimes I would get up and I'd go into the bathroom, do whatever I was going to do in the bathroom, and then I would look around for the cane. And I had left the cane in the bedroom because there was no pain.
Awesome.
I was able to walk from the bedroom into the bathroom with no pain, and that I had not been able to do that for.
Well, congratulations. That's fantastic.
Well, thank you.
You're making improvements.
Yeah. I was telling everybody.
Oh.
All right. Thanks so much for taking my call. I
yes,
really appreciate it.
Absolutely, Catherine. You have yourself a wonderful day. Thank you for calling in.
You too, sir. Bye-bye.
Thank you. A lovely call from Catherine there, updating us. And that was so valuable for everybody watching. That was like super good information there. It was working. She worked her way through the criteria for the phases of the hip arthritis recovery program. And for those of you guys watching that have knee arthritis, not so much hip arthritis, you can do the same thing with our charts here. So we have that available for you guys to go through. And I encourage you guys to ask questions like that on our chat, or we're here next week when we do that. You can definitely call in, and I'm happy to do that again for you if you can call in and do that. But we have the quiz available too. There's a quiz on our website so that you can just answer some simple questions. Here's our little video about it. Answer some simple questions and you'll be able to figure out what phase you're in. And on top of that, we'll send you a report about the phase that you're in so that you can get some helpful information about what you should and shouldn't do, and guidance on exercises. It's super helpful. It's like a 20-page report. And it's not that long to read. Like there's a lot of pictures in there too for you guys to access. It's beneficial for you as well. So on our website there, you can take our quiz. And then there's something else we're going to look at. Well, the program as well. So if you want help now, you're ready to start our knee arthritis recovery program, our website has all the information. You can apply. So we require everybody to apply for the program because we need to make sure that you're safe. We'll do a little quick 5-minute safety interview, and then we'll have a discussion about your just your history, what's going on with your knee and any other conditions you have, because we'll have to take that into account and give you the best recommendations on how to go about using our program. So if you're ready to apply, go to our website, check it out. If you want to just start with a quiz and see where you're at, you can find that on our website too. And we're happy to help you here on our live streams and our YouTube videos. If you're watching us on Facebook as well, we're helpful here on Facebook as well. All right, let's see what questions you guys have, what comments I can help you guys out with. Dan says, where can I get recovery program charts? Definitely on our website. If you just go to our website, epmanualphysicaltherapy.com, and then you'll see right away it'll load up. It'll say start now, something like that. There's a website. And then you go to our start now page for the knee arthritis recovery program. We also have one for the hip arthritis recovery program. It's on the main page there. And then you start playing the videos, you can see them there. Just a heads up, I'll be announcing it soon. We're in the process of developing a Kickstart program associated with those videos from phase 1. And so we'll have a way to email you the chart if you want it to. Right now we don't have that, but that's coming real soon. But you can screenshot it off here. Let me do this for you, Dan. Pause the video and screenshot this. And then you could do the same thing for the hip program if that's your thing, on that call we had earlier with Catherine. Good question there. Patty says, it works. I've been tightening my glutes for a month and my knees feel so much better. Thanks for chiming in, Patty. I had asked for those of you guys that have been able to tighten your glutes, glute activation, and you can get that quick relief to start to correct the problem. That's foundational. Now, Patty, the charge is on. Now you're doing the bridge stuff here. You need to move into the gold. Let's get those glutes stronger. Good job, Patty. Marianne says, when I told my orthopedic doctor how beneficial your program was and how I faithfully do the exercises, he said, I wish all my patients did that, but most want a quick fix. Yeah, it's so true. And this reminds me, doctors get it too. There was a great video out. It's like a comment moderator. If you can find this and link it on here. There's a video out there on YouTube from neurosurgeon who he's like out in nature, like on a hike somewhere, and he made like a 40-minute video about how he quit being a neurosurgeon because he realized he wasn't helping people. He was just doing these quick fixes. And he goes into detail about how his schooling went and how his residency went and all the training. And he's just like, I don't want to be a part of that. We're not really fixing problems. We're just putting band-aids on people. And he's like, I don't want to spend my time like that. He wasn't fulfilled. You guys might have already seen that. If somebody's seen it, link it on here. It's a really good video. It's got millions and millions of views. I think he's an Asian a guy, and he did such a good job on that video. You guys should check it out. But to your point here, Marianne, is doctors have a sense of this, and many of them are like, well, this is what I do now, and so this is what I have to offer. This is what my training's about. So I'm going to offer you the Band-Aid stuff, and if the Band-Aid stuff doesn't work, let me go to the trade-off stuff, the surgery, the other procedures, and if it gets really bad, amputation. And they're not trained in these bridges and gold stuff, but they have an idea that kind of needs to happen, but that's not their training. So good comment there, Marianne. Thank you. Nicole says, it's amazing how a lot of orth doctors don't recommend lifestyle changes such as diet, PT, exercise. Nope, they go straight to TKR, total knee replacement, in my experience anyway. Yeah, it's our system. I love this concept because it's everybody's fault, and it's nobody's fault, and it's their fault. Like the blame kind of goes around, and it takes the individual to stand up and make a decision. Like that neurosurgeon that I was talking about, he's like, I'm not going to be a part of this. But so many people, they have the dream of becoming a doctor one day, and then they get there and they realize it wasn't what they thought it was going to be. Sometimes some people absolutely love it. They're built for it. But I think this happens in any career, whether you want to be a teacher or a doctor, a lawyer, whatever it is you want to do in life. Like, you have this romantic fantasy about what it's like, and then you realize it's not what it was cut out to be, and they just hang out there instead of saying, I'm going to change careers, or I'm going to do things differently. That's what I did for sure. I realized when I became a physical therapist, I wasn't really helping. I was part of the system. I was part of the Band-Aid, and I said, I can't do that. There's a way to fix arthritis. Let me go help people do that instead. So you got to find the right doc for yourself, guys. Hopefully I can help you out, but if you need somebody in person, you got to do some digging, and we're happy to help point you in the right direction. But this system that I developed for knee arthritis and hip arthritis works very well if you can apply it. There's the video. Great, we found it. I was an MIT educated neurosurgeon. Now I'm unemployed and alone in the mountains. How did I get here? And there's the link right there. All of you guys should go watch this video. It's a little bit long, but it's totally worth it. And you could always play it a little bit faster, with your controls. Totally worth it. Mr. says, I saw the video from the surgeon. It made me think a lot about a lot of things in life. Yeah, it's such a good video. He was just raw on that video and just gave his unfiltered thoughts. You could tell he didn't really plan the video too well. He kind of goes along all over the place, but he's very articulated. Like, it's interesting to watch for sure. I resonated a lot with him, and I'm glad that we've been able to build this audience with you guys and help people the way we're helping people, because you guys see this and you see how the way that I'm talking about the problem corrected versus the problem just covered up, and how there's quick relief and long-term relief. I hope this guy's resonated with you. I hope this stuff resonated with you guys about how to look at this. And I wrote this in red on purpose because this is mainstream medicine down here. They just cover the problem. But there's more to it. Marianne says, what do you do when you have flat feet that is causing my knees to be off? I've tried the orthotics, but they never help. My podiatrist told me I needed new feet. So amputate them. That's what your podiatrist said. Just joking. No, Marianne, you need to strengthen your feet. You absolutely need to get stronger feet. And the question I always have whenever people tell me they have flat feet is, are they structural flat feet or functional flat feet? The difference is, you have structural flat feet if you've always been like this since you were a baby and it never got better. But an even quicker way to tell is if you just take off your shoe right now. I'll show you on my foot. Like I have a functional flat foot, which means it can be changed. You can adapt it. But if you look at my foot here, the one in the sock, when I'm not bearing weight on it, you can see an arch in my foot. I have an arch right there. Whew, my balance. There's an arch. But when I stand on it and I put weight, watch what happens. My foot flattens out. It collapses down. That arch collapses down. But if I use my toes and I get them stronger over time, I can create an arch. See how I'm making an arch by pushing my toes down? Then comes the work of figuring out how to make this a habit to use your toes and have stronger toes so that you have good arch support. Now, using an arch support in a shoe is a potential bridge because it might give you some temporary short-term relief. If you just leave it at that and expect the arch support to fix the entire problem, then you're treating it as a Band-Aid. That's something to note here. You can use some things will kind of go in both ways, in Band-Aid and bridge. I'm okay with you using Band-Aids as long as you understand how they're supposed to be used, that they're not going to fix the problem. A shoe insert, an orthotic, an arch support, all those things are the same thing. It's intended to support your arch if you have a flat foot, a functional flat foot. But what you should be doing is toe curls, because those muscles that curl your toes go under your arch and help to lift it up. That takes a while though. That's foot exercises. I have it in here. That's gold for you though. And if you can get your foot strength up, eventually start doing heel raises with your toes, using your toes properly, then you have a great shot at not having to use the foot, the arch supports, and being able to fix your foot issues and support your knees better. It's built into the program, by the way. In the knee arthritis recovery program, there is a pathway where you need to strengthen your foot muscles with the intent of better supporting your arches to take pressure off your knees. It's built in. Everybody goes through it. Good question, Marianne. Karen says, do you have information for people who can only bend their knee 95 degrees? Do we still start at phase 1? Notice on our chart here, Karen, we don't have degrees of motion. It's not a factor I built in intentionally, because it's possible that you never gain more than 95 degrees of knee bending and you work your way up to phase 4. We focus a lot on the knee bending, and it is important, but once you're about 100 degrees or so, if you're not going to gain any more motion, if no more motion is coming for whatever reason, you might have to give up a few things. Like maybe you can't reach your foot as easy, you can't put on your sock as easy, or tie your shoelaces, or clip your nails, or get your nails done. You yourself do them. You might need to just take that loss, but you can still keep your knee healthy with what you have moving on forward, even though you can't bend your knee all the way. That happens sometimes. However, what I suspect might happen is if you go through our program and truly correct the muscle imbalance, MI correction, you go through the bridge stuff here and then get to the gold stuff here. Your muscle imbalance correction means you're going to calm your quads down, which usually allows for more knee bending. It is very common for people to gain flexibility without ever stretching. They're just fixing the muscle imbalance. Getting the quads to calm down and using your glutes better usually gains people knee flexion, knee bending. So that's why I built it that way. You can still make improvements and live with a knee that doesn't fully bend. Medical professionals, though, will make a big deal out of that knee bending. And they'll tell you good reasons. They'll say, well, you need to be able to reach your foot and cycle all the way around on a bike. But I have seen people that can't fully reach their foot. They get help. There's devices you can get out there if it's just that big of a deal. But you can still do a lot of other things, even though your knee may not get better. But I would venture to say you can get another 5 or 10 degrees out of that knee if you fix the imbalance. Good one, Karen. Marianne says, what is your opinion on guided prolozone injections as opposed to cortisone? I am not educated on the prolozone, the ozone injections. I don't know much about it, but my strong suspicion is it's not. Let me give you this information. I'll put this is the framework that I use. It's a Band-Aid solution the ozone treatments, it's a Band-Aid solution. And any other treatment is a Band-Aid solution if it's not focused on correcting the problem. If it's just covering the problem, it's a Band-Aid solution or a trade-off. But if it is getting your muscles to activate better, directly decreasing the pressure in the joint, and it's sustainable for a long time, then we're correcting the problem. That's what all this is. We're offloading, taking pressure off. The massage gun is taking pressure off because you're massaging your quads. Glute activation is allowing your quads to turn off or be used less, decreases the pressure as well. All this is pressure related. Then over here, we're fixing the imbalance. If these injections don't help you with those factors, then they're just covering the problem, and that might be okay. You might use it for that benefit. But see, this is where it gets kind of borderline gimmicky. Like I look at all the injections that are out there. They come out with a new one, by the way, like every year, every other year. It's like the new iPhone release. Here's the latest new concoction that they've made up of gel injections, or the ozone injections are a newer thing that came out in the last decade or so. There's so many new things come out, and for me, I just start to think, man, it's almost like a gimmick. Like I don't dismiss it. Like it's potentially helpful for some people, but if you've already tried all these other injections, you've already tried all these other pain medications, you've tried ESTA, you tried vibration plates, you tried all these other things, and it's not working for you, you're not fixing the root problem. Let's double down on that. So you can do it. I won't ever ding you if you don't, Marianne. I won't ever ding you if you come on here and say, I had the injections already. I'll say, great, how did it work out? Hopefully it helped you, but are you working on your glutes? Let's get those glutes working. Let's get them working while you're walking. Good job. Nicole says, I think Robin meant the back of her knee, the bend. That is where I use it. Are we talking about the massage gun? Yeah, you need to be careful back there. Let me show you on the camera over here. If you're on the back of your knee, like right on the back where your knee bends most, there's a bunch of nerves and blood vessels there. And so you really shouldn't be using the massage gun here. But if you go down a bit on your calf muscle, or if you go up a bit onto your hamstring muscle, that's a good spot to be using the massage gun potentially. I'm okay with massaging those two areas, but generally the priority is massaging the thigh, the front of the thigh. The second priority could be the back of the thigh if we're talking about taking pressure off the knee joint to get some quick relief. Calf could affect the pressures in the knee too, but I find that affects it a lot less than the quads. Quads are the main one. And these quad muscles, they run all the way up into the front of your hips. So you might need to come all the way up here, maybe even right here, like where your pocket would be, your front pocket. You could massage in that area. The TFL muscle is a common muscle that loves to contribute to increased pressure and tension in the area all the way down to the knee. Be careful with the back of the knee, guys. The sciatic nerve is running back there. It turns into another nerve, but it's the same branches of the sciatic nerve. Cindy says, Dr. David, can you do a control flare-ups for hips? I know most crosses over from the knee to the hip inflammation. Thank you. Okay, so you're asking about like the flare-up management, I suspect, for hips. It would be exactly the same, offloading, using the massage gun. Tailgate swings are where it's different, though. That's the only one. So I would still say if you have hip arthritis problems and we're talking about how to manage flare-ups best, my top three, one is still going to be offloading, because if you can use that walker and get pressure off your hip this time instead of your knees, it looks the same. Like if it was I was showing you guys earlier my left knee and I would hold up my leg or just barely put a little bit of pressure to my toe, same exact maneuver is going to take pressure off my hip and my ankle for that matter. Some people have ankle arthritis. And I would still walk the same way. Just don't put pressure to that side that hurts so that we can offload the hip joints in this case. Then the second, if we're using the crutches, it's the same thing. Same exact thing. Same thing with the canes too. We just need two crutches. I would just take pressure off that hip. If we're talking about using the massage gun for the hip, it's still the same muscles, because these quad muscles, they go all the way up into the hip. One of them in particular, it's called the rectus femoris muscle. It's the right in the middle of the front of the thigh, and it connects to your hip bone, where you're most bony on the front of your hip right here. That muscle, that line of muscle right there is where I would be massaging. You might focus on some extra parts of your hip around the back of your hip, the side of your hip here, that you can massage gun as well. But it's generally the same thing for knee arthritis, because there's some people with knee arthritis that they're like, oh, there's a spot back here that, oh, let me release that one for 30 seconds and it gets better. You could do that. The tailgate swings, though, is definitely for knee arthritis. The alternative for hip arthritis is thigh fidgeting. So when you wiggle your hips like this, you're moving the ball and socket joint gently, comfortably, and you're circulating the fluid inside the hip joint. Because as I said for the knees, your blood system, which includes your heart pumps blood through all your arteries and veins, but it cannot move the fluid inside your joints because of the way that it's set up, the way that your joint is. There's fluid inside the joint that is circulated by movement of your joint, and it needs to circulate in order to move around in all the crevices of the joint and get good nutrients to the surfaces and bad stuff out, the waste products out. And so when you move like that, real nice and gentle, just, you shouldn't get tired doing this. It shouldn't hurt. You should just feel like you're fidgeting. People do this all the time. They fidget in their seat. My kids do this all the time when they're holding it for a while. And I got to ask them, come on, let's go to the bathroom. You should do this for a few minutes, 2-3 minutes, up to 5. I would be doing it consistently every hour, once an hour, while you're awake, of course. That will move the fluid and get you to manage the flare-ups. Those are my top 3. There's other things you could do as well, Cindy, but those are the top 3 that tend to work for the majority of people to manage the flare-ups. You could try medications and creams and injections, but you just got to know that those are not setting up your cartilage to feel better, to heal. It's just taking away the pain temporarily. All right, First Laurel says, my both shoulders hurt, so I can't use my walker anymore. And when I walk, it feels like my femur is pressing hard on my tendon. What can I do, please? Yeah, this is a tough one. I always feel for the people that have arm problems. You might, when you have multiple problems like this, you have to start to go through the questioning of which problem is most important to fix first, or can you at least make some improvements? Maybe not fix it all the way, but make some improvements so that you can use your shoulders. So you might need to go address your shoulders first, which we have videos that can address a lot of shoulder problems on our channel, and get it to calm down enough so that you can tolerate using a walker or crutches or something like that. In the meantime, you offloading for you might look like not moving much, just the absolute minimum. Get to the bathroom, get to food, get help if you can with whatever you can. And you need to prioritize the problems. It's just triage at this point. You're trying to take care of the most important problem first, the one that really limits you the most. Put out that fire at least some of the way, and then go address another fire, and you're just dealing with multiple fires. Or whack-a-mole, you're playing whack-a-mole. This problem pops up, and that problem, you're just kind of, that's the situation that you're in. And I'm sorry that you're in that situation, but that's the best advice I can give you. This situation is one where you might need to use the Band-Aid stuff to get you through the rehab of your shoulder, the partial rehab of your shoulder anyway, so that then you can get your shoulder feeling good enough so that you can offload, so that you can use a massage gun right now for sure. That should be doable for you. Hopefully that helps, First Laurel. Van says, I had a Baker's cyst drained about 8 years ago. Today I have poor range of motion and weight-bearing pain. Could draining the Baker's cyst have increased problems? Can synovial fluid be replenished? Yeah, your body, there's this idea of equilibriums. Homeostasis is another word that they use. Your body's always trying to maintain a certain condition in itself. One of those inside the joint is it tries to maintain the same amount of synovial fluid. The synovial fluid is made from components of your blood, so it gets replenished for sure. The problem that probably was still there is the muscle imbalance. That's likely what set up the loss of motion and trouble with weight bearing. For whatever reason, the Baker's cyst maybe didn't come back. It's possible for the Baker's cyst to pop, to rupture, and so you can't really get another Baker's cyst after that. This is what I've typically seen, but you'll get swelling in the leg all the way down into the calf and ankle, into the foot too. So if you have that, that's probably a reason why you have pain still in the ankle and swelling in the ankle, down in the foot. But I don't know that the Baker's cyst directly might have caused more problems. It's hard to say. But what's much more likely is that the muscle imbalance has continued to cause problems even after the Baker's cyst was drained. Remember, the Baker's cyst is a side effect of the muscle imbalance, and it typically happens with knee arthritis. The reason for a Baker's cyst, guys, the Baker's cyst is when you get puffiness in the back of your leg, like right where your knee bends back here. People will get, they call it a cyst because it's a fluid-filled sac, but it's the joint capsule, the part of the joint that just goes backwards, because that's where you have the least amount of stuff. That's where there's the least amount of resistance in your joint. So when you have an extra fluid development in here, it goes back. And doctors don't always see that as connected to arthritis. So they'll just say, oh, you have a Baker's cyst. And they don't give reasons why it happens. But the reason is your body, your knee, made extra fluid because it's feeling the extra pressure, and it's saying, well, if we make some more fluid, maybe we can heal and cushion the joint better. And that's because you have extra pressure from the muscle imbalance, the same muscle imbalance that sets up knee osteoarthritis. So the solution, the short-term Band-Aid solution that doctors like to do for Baker's cyst is drain it. But it covers the problem, it doesn't correct it. But if you can get the pressure off your knee, then your knee says, oh, we don't have to make extra fluid. Let's go back to our homeostasis, our equilibrium, the normal amount of fluid we have that we need based on the normal pressures that we're supposed to be having. We have to take the pressure away. So hopefully that helps you out. You can restore your synovial fluid, but we need to fix the pressures. David Formby says, hi, Dr. David, I have a Baker's cyst on my right knee. How would that affect me being on the program? It wouldn't. I would treat it the same way. The same exact treatment is necessary for somebody with knee arthritis as it is for somebody with just a Baker's cyst and no knee arthritis. Because if you don't have knee arthritis already, David, it's coming if you have a Baker's cyst. That's a sign that it's on its way. So definitely do the knee arthritis program for a Baker's cyst. There's not a separate treatment process. Robert says, how about shaving the bad meniscus with surgery? Oh my gosh, Robert, there are studies that have been done already. They don't do them in the US because we don't have government-run medical systems here for the most part. But there are studies done, was it Denmark or one of the countries in Northern Europe, where they did placebo surgeries. So they did a sham surgery and an actual surgery, meniscectomy. They had two groups of people, all of them had meniscus tears, but one group got a sham surgery, meaning they did everything normal like they would in the surgery. They put them under anesthesia, all the same staff was there. But when the doctor got to the meniscus part that they were going to shave or cut off, the doctor did not touch the meniscus. That was the experimental group. The control group got the typical meniscus surgery. The meniscus was cut out. Then they followed these people afterwards. The patients didn't know which group they were in. Because they all looked like they had an operation. It even says in the paper, such a well done study, that they even passed tools and spoke the exact same way that they would in the sham surgery versus the normal surgery. So they controlled for that. What they found 6 months later and 12 months later is that both groups, the group that had the sham meniscus surgery and the group that had the normal meniscus surgery, both groups improved the same. So then the question comes, why are we doing meniscectomies? Why are we shaving the meniscus? If it didn't really make a difference, they all got better. And there's other studies that show that conservative treatment, physical therapy treatment, also improves meniscus problems about the same as surgery. Then we're like, why even do a surgery? We're spending all this time and money and extra effort to go through a surgery. Now, those same people that went through that sham surgery and actual surgery were followed up 2 years and 5 years later. And what they found, Robert, was the people that had the meniscus shaved were more likely, way more likely, to get knee arthritis. And they didn't give reasons why, but my suspicion is that that chunk of cartilage, which is what the meniscus is made out of, even though it was torn, it was potentially still helpful for cushioning your knee joint and protecting you from having knee arthritis. Now, there's situations for sure where the meniscus is torn in a way or so severely that it's impeding motion, like it's not letting you move normally, and maybe surgery is right. But I think meniscectomy procedures are way overdone. We don't need to be doing them, and those studies are a landmark in my eyes anyway. It just proves my point about how surgery is overdone, and if we fix the muscle imbalances, we can reduce the pressures. And I've had tons of meniscus tear patients who have done very well. We've even made a program for it, the knee meniscus recovery program, and we teach how to fix the root problem so that you can depressurize your meniscus and let it heal, and then learn how to put normal pressures through your knees moving forward, so you're not dealing with knee problems and preventing knee arthritis and eventually knee replacement later on. Robert, you got me all riled up, but that was a good question. I love those surgery, the studies that they did. Daisy says, I'm 74 and sure to get a hip replacement in about 4 months due to bone-on-bone arthritis. Is there any chance I can start to recover before then so that I can put out of the operation? It depends on you, Daisy. It depends on what you do between now and then. We've had people sign up for our programs, our knee and our hip arthritis program, telling us, I have surgery in 2 weeks. I have a surgery scheduled in 4 weeks. Like they have an upcoming scheduled surgery. They start our program as a last-ditch effort, and then they're letting us know that they're calling to postpone or cancel their surgery. Now, I understand, and depending on where you live, what country you're in, what place you're in, all that, like it might be really hard to schedule those surgeries, and you might, if you delay it, it might mean delaying it for a year or more. If you just have to consider if you're okay with that. But just understand that surgery, I put it here in the trade-off. It's not fixing the problem. It's not correcting the problem. It's just covering the problem. And it's a lasting solution, meaning you can't really go back after you have surgery. With this, you can go back. You can do the gold exercises that I talk about. You can always end up still having the surgery if this doesn't work out for you. And that's what I recommend, because even if you do go through with the knee replacement surgery, this is so important for you to hear, Daisy. If you eventually go through with that surgery in 4 months, but you did the work to correct the root problem, and if you find that you still want to have the surgery, great. You're set up better now to recover faster from the procedure because you've been strengthening the right muscles, but also to make sure that you fix the muscle imbalance so that that surgery you have, the replacement parts that were installed, will last you longer. Because that's a consistent problem we find too, is people say, the doctors will say, this replacement's going to last you 10, 15, or 20 years. And what they're going off of is the data points they've gotten from their patients who have not fixed their muscle imbalances. And so their muscle imbalances are still overpressurizing their knee replacement and doing something to wear down the parts or loosen them. But if you fix the imbalance, correct the problem, hopefully that surgery will last you the rest of your life if you end up having it. You might feel better enough to say you don't want it too. I hope that's the case. Barbara Smith says, hi, this is Barbara. My podiatrist says I have heel spurs, which is a form of arthritis. So he said I just have to live with it. It's got to be something else that I could do. Yep, there is other things you could do. With heel spurs, do I have my foot model? Yeah. There's different ways to get heel spurs. The most common one is going to be, get out of the way here, right here, this point right here. This is where the plantar fascia attaches, and you can get a heel spur there. You can get a heel spur in other parts of your ankle though. What you have to realize with any bone spurs is that they are not usually tearing things, cutting things. Because whenever we hear spur, we think of like a thorn or a hook, something sharp that cuts or grabs onto things. And the better way to think of it is when there's a bone spur, like the one that I'm talking about, we'll just use that one as an example, the one that forms here, because you already naturally have a little hook there, but it gets elongated. But what you don't see on this bone model is in the body, there's a big, massive tendon there, the plantar fascia, a ligament, whatever you want to call it, the fascia. It attaches right here and it's pulling. There's tension through it. And if there's excessive tension through it, the bone adapts by elongating into the ligament or tendon. So it's going into it. And the bone does that as a pressure response, just like getting calluses. Like I got calluses on my hand right there from lifting weights. You see them? They're darker. Got a little blood in this one right here. No, this one right here. Because I was hanging from a bar and picking up heavy weights, and my skin said, that's a lot of pressure. We're going to tear unless we get thicker here. And as long as it's not too much too fast, because if you do too much, obviously you're going to get a blister and it's going to pop open. You can get to the deeper level of skin. You're going to get blood, all that stuff. But if it's the right amount of pressure, the body has time to respond, and it responds by getting thicker. Your bones do the same thing. The bone elongates right here, forming a spur. Same thing happens in the knee joint in order to protect itself from detaching, because the tendon's being pulled here. And if it has time to adapt, the bone just says, let's just grow into it and anchor ourselves in better. So the solution here is to fix the imbalances, fix the pressures so that we're not worsening any sort of bone spur. The way you fix it in the foot is by getting stronger toes. People don't have enough toes. We live in shoes. Most people are in shoes all the time. And even if you're more of a barefoot person, you don't always think to curl your toes and have good arch support. So I promote people, I tell people a lot, I promote it a lot to get stronger toe curls. You have to be able to curl your toes and then translate it to everyday activities like standing. Like when you're standing up, your toes should be subtly grabbing the ground. And the more intense the activity that you're doing standing, the more your feet should grab. So like when I go pick up heavy weights at the gym, I stop for a moment and think, toes down, and then I get all my other muscles ready, and then I'm doing my weightlifting. My feet are getting a workout that way. That's how it should happen. So we have all kinds of videos on this, Barbara. Go look at our videos on foot stuff. You'll definitely catch it. Remy, Rahim, can't say this one. I'll just call you R. Hello, doctor, and the team from Ethiopia. Oh my gosh, Ethiopia's here. That's so cool. I am diagnosed with bilateral chondromalacia patella, my left leg being at stage 4, but my right leg is painful. Need your assistance on how to deal with it. Thanks. Oh gosh, sounds like you got to fix the muscle imbalances. We'll first start off with offloading. This stuff still applies, by the way. Patella, chondromalacia patella, is the beginnings of knee arthritis. I'm sure a lot of you guys can chime in here. If you have knee arthritis already, you guys have probably had a meniscus tear, chondromalacia patella, possibly an ACL tear when you were younger, and patellofemoral pain syndrome. One of those 4 things often happens before knee arthritis. Probably like 60 to 80% of you guys have had that. So if you already have that, you're on your way to knee arthritis, but you can stop it by dealing with the flare-ups. And it's the same procedure here, by the way. I would be offloading, I'd use a massage gun, and I would do some tailgate swings. The good thing for you is it's going to go faster, because if you don't have knee arthritis yet, it's less severe for you. Usually what slows you down the most at this point is just whether or not your glutes can activate. Once you get your glutes to activate, then you're going to be fixing the muscle imbalance. You need to strengthen those glutes, strengthen your foot muscles and your abs. And as you get those muscles stronger, your quads should calm down, which decreases the pressure on that patella. That sets you up to heal in that cartilage behind your patella. It's a very fixable situation. Most importantly, what this does for you is it sets you up to move right, to have the right balance in your muscle strength around your knees, so that you're avoiding knee replacement later on. So that you're avoiding knee arthritis. And of course, don't have to have a knee replacement. So there's a whole process to this. I actually made a program called the Patella Pain Recovery Program. You can go check it out on our website. It's directly treating chondromalacia patella and other patella-related problems. So we have help for that. And we have a bunch of videos on chondromalacia patella as well, free on YouTube. Love it. Lovely Jubbly. I love this name. All this should be taught to children when doing PE. I 100% agree. If the kids are taught about glutes, it will become part of life for them and prevention. Yes. Oh my gosh. I couldn't agree with you more. I mean, but I went through school with, PE coaches, other educators that they didn't know this stuff. And I don't blame them. Like I said earlier, it's everybody's fault and it's nobody's fault and it's their fault at the same time. But it's the education system. It's the way that we're set up. It's that we don't have enough research to prove that this stuff works enough to convince the schools to teach this as normal stuff that everybody gets taught, so that it trickles all the way down to kids getting taught in PE to use their glutes when they squat or when they run or whatever it is that they're doing. So the best we can do right now is you got to learn this stuff and teach other people about it. Good comment there, Lovely Jubbly. All right, guys, we're going to wrap up. We got one more comment we're going to take. Kayleen, you're the last one. Dr. David, I just want to say a big thank you for your amazing programs. Aw, thank you. You're welcome. I've spent time in your HIP program, and I am still working on it. I am seeing such amazing changes to my body. Thank you. Congratulations, Kayleen. I'm so happy for you. Love it that you're getting a benefit. I hope you get all the goals reached, that you don't have to have a joint replacement surgery, and that you can get back to doing all the things you love to do. And I wish the same for all of you guys watching here, whether you're in our programs like Kayleen or just checking out our free stuff. That's totally fine. I want you guys to get the benefit no matter what. Thank you guys for joining us this week. I'll catch you all next week. Have a wonderful week.